The next area to move on to, after the introduction and finding out a bit more about your patient, is to move on to the body chart. The body chart is a critical area for determining where pains are and what the pain is like. So to begin with, you will have on your notes a body printed, and it's important at this stage to fill in the areas of pain where they're presenting with their problem. These should be marked out and determined very specifically, and this may involve asking the patient to point to themselves where the pain or areas are. If there's only one area, that is simple, but there may be patients that have 2 or 3 or 4 areas of pain, and these need to be labelled separately: pain A, pain B, pain C, pain D, and they should be clearly demarcated. The pain also needs to be given a quantity, so you should try to find out how much out of 10 they give their pain. So 0 is nothing, 10 is the worst pain. Where would you put your pain at the moment? You also need to find out what type of pain, and this will give you an indication of both the pathology and potentially the tissue at fault. You perhaps need to note any other sensations such as clicking that may be associated with the problem, and any stiffness that may be also associated with the problem. Where there is no pain, a tick should be put on the body chart to indicate that you've asked and cleared and checked that there is no referred pain into this area. It is also worth noting at this point that you should also ask about more neural symptoms such as pins and needles, paresthesia, and numbness or anaesthesia. As we go through various parts of the body, there may be some special questions which you need to consider around the body chart, such as headaches, dizziness, double vision associated with the neck, and we will consider these separately. Next, it is useful to move on to the symptom description, in other words, the location and the type of pain. So following on from the body chart, where you may already have determined the quality of pain, whether it's aching, throbbing, burning, and indeed the intensity of the pain with the VAS or visual analog scale. You may also like to know about how deep the pain is and how this relates to their pain. Any abnormal sensations they may be feeling, and whether the pain is constant or intermittent. Once you've determined the type of pain, it is useful now to move on to how the pain behaves, or the behaviour of symptoms. And this is known as the aggravating and easing factors. These are an important component of the subjective examination because it gives you a determination of how severe and how irritable the problem may be. So the aggravating factors are things that aggravate the pain. So it may be a movement or a posture that increases the patient's symptoms of pain or stiffness. What you need to find out is how much of that movement, for example climbing stairs, brings on the pain. Do they have to only climb one stair or a whole set of stairs? And then to determine the irritability, you need to find out how long it lasts for after you have done the provocative movement. So for example, it may die off straight away as soon as they get to finish the stairs, or it may last for a few minutes, or indeed it may last for a few hours or towards the end of the day. An aggravating factor is a very important feature and will help you to determine your objective examination. If the patient can't think of a particular aggravating factor, it may be useful to have some up your sleeve to offer. For example, fastening a bra, or going upstairs, or looking over your shoulder. It is also useful at this point to gather an easing factor, and this will help for you to decide what posture or movements help to ease the pain, and therefore maybe determine how you will help to treat the patient. Continuing on with the behaviour of symptoms, we move on to the 24-hour pattern. The night symptoms of how the symptoms vary from night to morning to evening is a really critical way of determining again the pathology of the pain, but also perhaps the stage of the condition. Night symptoms. It's important to ask about the night symptoms. This will determine the severity of the pain. If the patient is woken up multiple times through the night, then you know that the pain is relatively severe. How long does the pain last for? Does it stop them falling asleep? Does it wake them up? If so, how often and what position? It is useful to use this information with information about how they sleep. So, do they sleep on their side, supine, prone? How many pillows do they have? What is the mattress like? These are important information to gather about their sleep pattern. The morning symptoms are also important. What do they feel like on waking before they move up? Is there pain there then? If so, this may indicate an inflammatory condition, which gathers the inflammatory mediators overnight where they pool around the tissues and cause the irritation to the C fibres of pain. Once you've found out what it's like on waking, you then need to find out how it develops as they start to move. Does that then reduce, in which case that supports the inflammatory hypothesis, or does it start to get worse, in which case you're thinking of more of a weight-bearing degenerative type condition? And then it's useful to consider the symptoms as it evolves through the day. Does it constantly get worse, in which case it may be an arthritic problem or maybe a postural problem? Does it perhaps get better? And this may indicate more of an inflammatory type condition.